So I'm Dr. Arthur Jason Luigi. I'm currently the chair of physical medicine and rehabilitation and in sports medicine here at Mayo Clinic, Arizona. So today I'll be doing a live demonstration on musculoskeletal ultrasound of the foot and ankle as part of this course, the Mayo Clinic Sports Medicine Symposium. So I have a volunteer here today, Julie Poad, which was one of our physical therapists in the department. Today we'll be showing you the assessment of foot and ankles. There's a lot of different variations of what you can do from musculoskeletal ultrasound of the foot and ankle. But for many of you in the audience today, you may have different levels of background in ultrasound. So today's demonstration is mostly going to be on what your basic exam would be. And then there's definitely other more advanced examinations that can be done. For the most part, the foot and ankle it can be a little bit challenging compared to some of the other body parts because of the curvilinear nature of the foot and the malleoli and how they will kind of change that contour. So there's a number of different things you can do with positioning to make sure that you get the best imaging possible. So frequently we'll use a linear probe like this here, so we would be able to get that. But as you can see with the curved contour, you may need additional standoff gel to be able to get that imaging. Or in some of those areas, we can also consider using the small footprint from the hockey stick. So for the majority of today's evaluation, I'm going to be using the regular linear probe. But if I should not be able to get the best images for you, I will switch over to the hockey stick. When we're doing the musculoskeletal ultrasound of the foot and ankle, we break it down into different compartments. There's going to be the anterior compartment, medial compartment, lateral compartment, posterior, and plantar surface. Today, we'll be starting with the anterior component. So oftentimes, I'll have the patient in the position that I have Julie set up as of now. So this allows, it will open up the joint so you can see the talar dome, and you can see the tendons, musculature, as well as neurovascular bundle in that area. When you're looking at this area, you'd be able to assess if there's an ankle effusion, if there's any bony defects, tendinopathy, or entrapment. So when we're scanning the foot and ankle in the anterior compartment, there's two different ways you could potentially start. You can start with the probe set up, in plane with the joint, or you could set it up in plane with the tendons, muscles, and vessels will pass perpendicular to the joint itself. So here I have it currently set up in anatomic longitudinal, so it's in long axis. So as you come up here, you'll see the tibia on the right-hand side of the screen. And as you scan down, you'll see the talus coming in here. And so they make up the tibiotalar joint or the true ankle joint. So this here would where you'd start to be assessing for whether there's any cortical irregularities from a talar dome defect, a joint effusion, perhaps either from trauma or rheumatologic disorder. And so you could scan along the length of the tibiotalar area as you look through here. And so again, you're just scanning back and forth in long axis. As you can see on the top of the screen, you'll see those, you change over the different tendons and vessels as you're passing back and forth. But initially, I'm focused on the deeper aspect here, looking at the joint space itself. At this point on the screen, my probe is placed in anatomic transverse or short axis to the tendons and the neurovascular bundle as we come in through here. So I have the probe set up so that the left side of the screen is the medial aspect of her ankle, and the right side of the screen is the lateral aspect of the ankle. So when we're coming down, you'll see going from medial to lateral. So you'll have the tibialis anterior, and then you'll have extensor hallucis longus. You'll have the neurovascular bundle, which is made of the peroneal vasculature, as well as the deep peroneal nerve. And then you have the extensor digitorum longus. So as we're going across the screen here, we'll be scanning down. As we move distally, we will be coming off the tibia where we are now, and we'll start coming over that joint space as you're starting to see in that deeper structure, the tibia is ending, and it looks a little bit more heterogeneous right now. And then we pass here right to the top of the talus. So this would be the talar dome. As you're going distally off the tibia here, you're sliding down. This is the joint space deeper. And now we come across and we get to the point where we're able to visualize the talar dome. So you'd be looking here for any cortical irregularities, if there's a concern for any talar dome lesions, as well as you could still assess the tendons for tendinopathy, or you could express any entrapment of the neurovascular bundle. And so you could see the pulsatile effect of the arterial flow there for the dorsalis pedis. Move across the screen here from left to right. You are seeing the tibialis anterior, a little bit deeper or superficial to the talar dome would be the extensor hallucis longus. Then just lateral to that, moving to the right side of the screen, would be dorsalis pedis. Just superficial to that would be your deep peroneal nerve. And you also have the venous system as well there. At this angle that we have right now, you see deep is the talar dome. Going again from medial to lateral, right to left across the screen, we're going to see tibialis anterior. Then we'll be moving to extensor hallucis longus. You see the pulsatile effect of dorsalis pedis. Superficial to that is the deep peroneal nerve, and you have the other venous vasculature as well before we move over to the extensor digitorum longus. So as you're coming down, you can continue to follow them into the foot. From this point here, we could follow individual tendons, where we come back across here. This is going to be long axis or in plane. So as we're coming across here to medial, so you could get tibialis anterior, and then you could follow it down into its insertion point. You could also do the same for extensor hallucis longus, as we would scan all the way down to the big toe, follow it down and through here, as it would activate and extend the great toe, as we're getting a good look here at the tendon here coming in from proximal to distal. And then you can scan back proximally. So you're following that tendon here from distal to proximal and long axis as we go back up across the metatarsals and then back up to the tibiotalar joint. Here again is where I talk about that change of the footprint. As you can see, my probe's a little raised on her skin, and so I just have to do a little bit of a tilt here on the probe. So, but now we're not having contact on the distal aspect, but we're able to continue following the extensor hallucis longus more proximally. Just medial to the extensor hallucis longus again would be your tibialis anterior, as we could see here, and it's coming down and inserting on the first metatarsal. Again, you could follow each of the individual extensor digitorum longus as they would go to each of the other four toes. But for the sake of time in this evaluation, we will not do that here, but you could individually follow them to the extent. As we are able to follow the tibialis anterior and the extensor hallucis longus to its insertion point, you could also do that for each of the four individual tendons of the extensor digitorum longus, but for the sake of this demonstration, we will hold on that assessment. So moving on from the anterior compartment, we're going to transition the patient to an assessment of the medial compartment. In doing so, I was able to just have her transition her positioning, from having her knee flexed and her foot flat on the table to hip abduction. In doing so, I also provided a little towel underneath just proximal to the ankle joint, so that her foot does not invert and allows a better assessment of the tendinous and neurovascular bundle that passes through that area. Again, from this evaluation, there are many other things that we could potentially add for a more advanced assessment, such as a tarsal tunnel entrapment. But for now, we're going to be just focusing on the anatomy and identifying any potential pathology that you would see from tendinopathy. From this position, we are above the malleoli. So this would be the supramalleolar evaluation. As we were looking here, we will, the tendons in the neurovascular bundle obviously pass proximally to distally below the malleoli. So there would be an inframalleolar approach as well. So as we're moving in this view, in assessing the tendons and neurovascular bundle in the supramalleolar region, we will be looking from anterior to posterior, left to right on the screen, posterior tibialis, flexor digitorum longus, the neurovascular bundle, and flexor hallucis longus. So as you come through here, the very first tendon that is at the superior aspect of the screen is the posterior tibialis. Just inferior and to the right side of the screen here, which would be posterior, is the flexor digitorum longus. So Julie, can you flex your toes? So you can see that coming through here. As you can see that live evaluation. And then you can see that neurovascular bundle here. There are some times where you would look at the vessel and it will have a paired venous flow. And so there are some occasions where you can get that image to look like Mickey Mouse ears. So I don't have that currently in the screen, but I will get that at some point in through here. You could see the tibial nerve, which is honeycomb shape and appearance there. And Julie, if you could flex your great toe, you could see the activation of the flexor hallucis longus. So at this point, we are just adjacent to the malleoli, and you could see the posterior tibialis coming right intact with the malleoli. Again, the flexor digitorum is still passing there. You are able to see a little bit more of those Mickey Mouse ears of that neurovascular bundle in which you can see the pulsatile effect of the arterial flow, and the flexor hallucis longus is deep. Again, at this point, we are at the level of the malleoli, and we'll be scanning just coming from proximal to distal, passing right below the malleoli. So here again is where having the smaller hockey stick footprint could potentially help because, based on the contour of the foot. You can make up for that by placing a little bit of a pocketer gel, which would be standoff gel at this point. So you apply less pressure, and so you can be able to get that, fill that contour with gel itself. So as we're moving here, as I demonstrated, I was not able to switch over to the hockey stick. I was able to use the current probe that I have, the traditional linear probe in through here. And again, you can see that posterior tibialis, the just adjacent to that posterior, moving from left to right, the flexor digitorum, the neurovascular bundle, as well as the flexor hallucis. You can also scan each of the individual muscles in the long axis down to their insertion point. So again, you have to change the contour of the probe. As I'm coming from proximal to distal, you have the posterior tibialis that's hugging that medial malleoli. So once when you get to that medial malleoli, the contour changes, so you have to kind of rotate the probe to get that best contact to follow that tendon down to its insertion. As we demonstrate here, is it coming down and then inserting, going again from proximal to distal as we come across. Like the extensor tendons, they will insert on the great toe and each of the 4 individual toes. The flexor tendons will do the same, and you can follow them out for the entire length and duration down to the toes. While I have Julie in this position, I'm able to assess the plantar fascia, just moving distally from looking at my medial compartment. As you can see here on the screen, you can see the plantar fascia inserting in the medial calcaneal tubercle. So that is going, the medial calcaneal tubercles on the right side of the screen, and the plantar fascia will extend distally as we slide the probe from proximal to distal. You could see the screen moving, and you could follow that plantar fascia across. As you can see here, the thickness of the plantar fascia is homogeneous throughout the entirety. There's no areas of thickening. I do not see any areas of hyperechogenicity or for calcification. That could be any plantar fibromatosis that may occur in the area. You could follow it distally as we go. You could see the underlying foot musculature that will go to the toes. You could see there, big thick muscle that's deep to the plantar fascia is the adductor hallucis. But as we're now moving back from distal to proximal, again, just looking at that that linear plantar fascia as it's coming down. And here's where you have to do a little bit of change into position to follow that plantar fascia as it starts to dive deeper, and then insert back into the medial calcaneal tubercle. At this point, we've been able to go through the anterior, medial, and plantar aspects of the foot and ankle. I will now have Julie transition and reposition so that we can assess the lateral, followed by the posterior aspect of the foot and ankle. I'm going to place a little bit of a towel underneath Julie again to try to open up the joint so it doesn't close on us. Here we'll be looking again at supra and inframalleolar evaluation of the peroneus longus and brevis. As you can see, they are adjacent to the malleoli. The longus is the long tendon and the brevis is the short tendon. As we come down here across the malleoli, this is where the evaluation gets tricky, but it's also a site where you're going to frequently see pathology as the tendons pass across this bony prominence. So the brevis is going to be on the left side of the screen and the longus is on the right, adjacent to the malleoli. So I'm passing along the malleoli very slowly here, trying to maintain. You can see that I'm starting to get a little bit of loss of contact. So let me go back here. So I'm getting a loss of contact based on air passing in between the probe and the jelly and the foot. So to help with that, I will make it a little adjustment with Julie's foot temporarily by holding it up in the air, which will allow it to flex. You can see a little bit of air coming into that right there. So, but I'm just going to pass over here. So here is be one of those times where the small footprint will go over. So I will, for this demonstration, finish with this linear probe, but this would be one of those areas where I could switch over to the small hockey. As you're coming across this area, passing over the bony prominence, you lose contact. So this would be one of those things where you could switch over to the other probe for this assessment to be able to get a better view. However, you can modify it by coming just inferior. I've provided a little bit of lift underneath Julie's ankle so that she will be, it would put her more in inversion. So I can kind of pass the probe around the malleoli while keeping the tendons in view. I'm at the level of the malleoli, and I'm now coming to become inframalleolar. I'm going to now slide the probe around the area. As you can see here, the peroneal tubercle is coming into view on the left side of the screen. And this here is another entrapment site, as the tendon can sometimes abut against the peroneal tubercle and cause a partial tear. So then you were able to pass through here, coming down to the insertion point of the peroneus brevis. The peroneus longus dives deeper and will then traverse underneath the foot and insert on the medial aspect. I've now transitioned the probe so that I would be able to evaluate the tendons and long axis. What I have obtained on the screen at this point is the peroneus brevis inserting into the base of the fifth metatarsal. So you can see that the insertion point on the left side of the screen, which is distal, and then proximal going from left to right. We're going to pass here now proximally. You can see peroneus brevis passing adjacent to that peroneal tubercle, which is an entrapment, and then coming around here. So this is where it gets tricky again to navigate around the malleoli. So I'm applying a little bit of a tilt to change the angulation as we come across. So coming back here at this point, this here is a key pathologic point here, that peroneal tubercle. And I'm going to center it into the screen for right now. So I have the probe placed here at the peroneal tubercle with this as a center point. This is a key point for pathology of the peroneal tendons. I'm going to be scanning from dorsal to plantar. As you can see, those two tendons will intersect at this area, and hence the site of pathology with the intersection as well as the bony prominence. So you would come back down across here again to get the peroneus brevis as it's coming down and inserting. So with the assessment of the Achilles tendon, we want to try to take out any laxity. So as you can see, the natural position would put her somewhat plantar flex, but also it provides laxity into the Achilles tendon. You could either put a pillow or you can take a roll. Here I have a blanket, which I'm going to lift her foot up and put it in through here. So now we're able to have it more of a flat surface here to get better evaluation of the Achilles tendon. I will then use additional gel here to place on her Achilles. Now that I have Julie in a prone position and I have elevated her leg with the rolled blanket, again, you can use a pillow or a foam roll if you have it in your office. I'm able to get a great image of the Achilles tendon insertion. Where I have the probe placed now, I have distal on the left side of the screen and proximal on the right. As you can see, Julie's insertion point looks great. You do not see any cortical irregularities. You do not see any hypoechoic thickening of that tendon. There's no evidence at this point of any insertional Achilles tendinopathy. However, there's also times where you can have more proximal. We're going to be looking for any changes in the echogenicity as you move from distal to proximal, as well as any focal areas of thickening. As you can see, there's no changes in the echo texture or the thickness of her Achilles tendon as we move distal to proximal. You can continue to follow the tendon all the way up to the myotendinous junction, to the gastroc, to the soleus. Again, you can continue to scan, looking for any muscular tears, should that be a concern based on the patient's presentation. I'm going to now scan again back from proximal to distal as we are moving across the screen, again, looking for any changes. Once I get back to the insertion point, I'm going to rotate to probe, anatomically transverse, to get the tendon. Here is where it's a little bit challenging, again, with the linear probe as we move through here. So I'm going to start more proximal, and I'm going to, you can see that very small sliver of tendon right in the center of the screen. That's right at the myotendinous junction. As I'm going from proximal to distal, you could see thickness of the tendon become more prevalent. Now you see on the screen here that there's a little bit of air passing on each side. Again, transition to a small footprint hockey stick could be beneficial, but I know not everybody has the access to having multiple probes in their practice. You can see here that transverse view of the tendon. You're looking for any irregularities, any hyperechoic areas for calcific tendonitis, any disruption or tears. So again, you can follow the Achilles tendon distally until its insertion point on the posterior calcaneus. And again, there is absolutely no cortical irregularities or changes here, and it looks great. Well, this concludes the live scanning demonstration of the foot and ankle utilizing musculoskeletal ultrasound. In summary, we have reviewed the anterior, medial, lateral, and posterior compartments as well as the plantar surface. The majority of the pathologies that you'll see in your clinic will be able to be assessed utilizing musculoskeletal ultrasound using the techniques that I demonstrated today. There are still some high-end, more advanced procedures and evaluations that can be done. However, additional training and mastery of these basics is paramount to you being able to provide the best care to your patient. Again, I'm Arthur Jason DeLuigi, Mayo Clinic, Arizona. Thank you.